So the partial trial is a randomized control trial comparing a newer way of doing radical prostatectomy where we're preserving some of the more native structures such as the fascia overlying the prostate. So it's been called the hood technique. It's also been called the Retsia sparing technique, and it was first described about a decade ago, and it's been adopted, but we don't know the long-term differences of patient recovery in terms of continence, regaining sexual function, or cancer control. So we're doing a randomized trial at multiple centers to answer that question with the primary endpoint of cancer control. We're all here to learn new things, and the Learning Lab this year is I think a new platform. So I'm excited to highlight our work, and I think it's hopefully an opportunity for young investigators, those who aspire to do clinical trials, to learn some of the challenges and how to navigate to try to make some of these things happen so that one can make a contribution to the field. Absolutely. So I think in surgery, oftentimes we do things because we're taught a certain way by our teachers, or there's dogma, there's not really a whole lot of evidence. And I hope that by doing a randomized trial with partners at Johns Hopkins, at Georgetown, as well as Northwestern, that we can really define the way that we should be doing radical prostatectomies moving forward to benefit our patients.
Our study looked at men with BPH and OAB and looked at treatment with the beta-3 agonist Vibegron and resolving their OAB symptoms, which persisted after treatment for their bladder outlet obstruction. The idea here with this particular medication, Vibegron, it's a once-a-day pill. It's a fixed dose at 75 milligrams without any titration. There's no hypertension warning in the label, which is good because it's a beta-3 agonist and people are concerned about that. There's no drug-drug interaction. It doesn't work. It's not metabolized in the liver by 2D6. And it's a nice crushable pill for those patients that come into the office and can't swallow one. So you sort of now have a good medication, a very good medication, which fits in a drug class which is now being recognized to resolve the real bothersome symptoms. Someone has decreased flow, incomplete emptying, all the problems of obstruction. You treat them pharmacologically or surgically. Now they still have frequency and urgency. They're getting up at night, and they may even lose urine from urgent incontinence on the way to the bathroom. So now you have medication to treat it because nobody comes back happy after treatment for their outlet obstruction, medically or surgically, if they still have OAB symptoms. I think it's important that we have a large armamentarium. This is the pharmacologic treatment. There are behavioral things that you can do. There are pharmacological things that you can do. There are minimally invasive OAB treatments that you can do. So in the pharmaceutical arena there, I think that we have really good data on 1,000 patients randomized and given treatment versus placebo, and seeing these patients improve in all 6, the 2 primary and the 4 secondary outcome variables, as early as 2 weeks.